Okay, so good day, everyone. So our topic for today is brainstem lesions. So what we shall be doing is we shall be localizing and analyzing the different brainstem lesions. So I'm Dr. Dennis Bravo, and I'll be your lecturer for this topic. Let's start our discussion first with a short case. So a 58-year-old man was referred to you because of recent onset of left hemiparesis, left-sided loss of proprioception, and right-sided tongue deviation. So our first question is, what are the CNS structures that are affected on this case? And number two, explain the symptoms based on the structures that are affected. And number three, where is the lesion localized? So needless to say, the lesion that we are talking about here is localized in the brainstem. I'm sure you are scratching your head right now on how to localize this lesion based on all the symptoms that we have presented here. So for some of you, you might find it a little bit of a challenge. So our goal for today is to guide you in the localization process so that you would be able to recognize and localize a brainstem lesion. So before we proceed, the structures, the lesions that we're going to discuss today are considered to be infratentorial because as you recall, in the previous lecture, at the start of the semester, the brainstem is an infratentorial structure. Now, if you're going to compare the manifestation of an infratentorial lesion like that of affecting the brainstem, you would see that there will be alternating signs, which means that the lesions would affect the contralateral side of the head and neck structures, ipsilateral side of the head and neck structure, while it affects the contralateral side of the structures below the neck. In contrast, for supratentorial lesions, the manifestation would be all on the contralateral side for structures located above the neck and below the neck. Now, before we proceed with the lecture proper, here are your learning objectives to guide you with today's lesson. So what are expected of you? So the first is that you should be able to localize brainstem lesions based on patients' signs and symptoms. And number two, you should explain the signs and the symptoms of the brainstem lesions based on the neurologic structures that are affected. So what will be covered in today's lecture? We'll have a brief review first of the brainstem structures. And for this, we're going to make things easy by following what we refer to as the rule of four. And then we'll review the different functions of these different brainstem structures and what would be their manifestation if there's a deficit in this particular function. And finally, the main bulk of our discussion will be focused on the different cases. You shall be localizing those brainstem lesions using the technique that I will be teaching you today. So now let's have a brief review of the structures that are located within the brainstem. So remember that the brainstem is composed of three major structures. This would include the midbrain superiorly, the pons in the middle, and the medulla oblongata inferiorly, which of course is continuous with the spinal cord. Then there are the different cranial nerves that actually arise from the brainstem. This would include cranial nerve number 3 all the way up to cranial nerve number 12. Now, the location of this and functions of these different cranial nerves are very important for you to remember. So trust me, it's not that difficult. To make things easy, let's follow the rule of 4. So this is a simplified method for understanding the anatomy of the brainstem. And this will help you localize the different brainstem lesions. So in other words, there are 4 major concepts that you need to remember to help localize the brainstem lesion. So what are included in the rule of 4? Rule number 1. In the brainstem, there are 4 medial structures that are very important, and they begin with the letter M. So that's not really hard to remember. Medial corresponds to M. Rule number 2. Of these medial structures, some of them are actually the motor nuclei of cranial nerves number 3, 4, 6, and 12. Now, if you remember your basic math, 3, 4, 6, and 12 are divisors or factors of the number 12. Rule number 3. In the brainstem, there are 4 important side structures, and they all begin with the letter S. And finally, rule number 4. This refers to the distribution of the different cranial nerves in the brainstem. 4 cranial nerves are located in the medulla. 4 cranial nerves arise in the pons, and 4 cranial nerves are located above the pons. 2 of these cranial nerves are actually located within the pons, while 2 are supratentorial. So as not to deviate from the concept that we're presenting today, let's just say 4 cranial nerves are located above the pons. So what are these 4 important medial structures that begin with the letter M that are located on the brainstem? One of them is the motor pathway. Of course, the formal name for this is the pyramidal tract or the corticospinal tract. Then there's the medial lemniscus, the medial longitudinal fasciculus, and the motor nucleus and nerve of cranial nerves number 3, 4, 6, and 12. So this cranial nerve, their nuclei are medially located. That means that the nuclei of cranial nerves number 5, number 7, number 9, number 11 are lateral in location. Now, what about rule number 3? The 4 side structures that begin with the letter S include spinocerebellar pathway, the spinothalamic pathway, the sensory nucleus of trigeminal or cranial nerve number 5, and the sympathetic pathway. And the last rule, the distribution of the different cranial nerves on the brainstem. Now, 9 are cranial nerves number 9, 10, 11, and 12 originate in the medulla, while 5, 6, 7, and 8 originate in the pons. And finally, number 3 and number 4, cranial nerves number 3 and number 4 are located in the midbrain. Now take note, cranial nerves number 1 and number 2 are not located on the brainstem, and therefore is beyond the scope of what we need to learn for today. So just simply remember this rule of 4, and you would actually survive and be very adept in localizing the different brainstem lesions. Okay, so now let's move on to the different functions of these different brainstem structures that we have mentioned. And let's also review the corresponding signs and symptoms in case there's a deficit affecting these neurologic structures. Let's start first with the medial structures. This would include the motor pathway, otherwise known as the corticospinal tract, the medial lemniscus, the medial longitudinal fasciculus, and the motor nucleus and nerve of cranial nerves number 3, 4, 6, and 12. Let's start first with the motor pathway. The formal name, of course, is the corticospinal tract. If there's a lesion affecting this pathway anywhere along the brainstem, the manifestation is contralateral weakness or paralysis. Let's trace this pathway based on its origin and destination. So we all know that the corticospinal tract originates from the cerebral cortex, primarily from Brodmann area number 4, or the primary motor area. So the neurons here send out axons that would descend downward in the brainstem. Now, upon reaching the medulla oblongata, 90% of the fibers cross over to the contralateral side. This is what we refer to as the pyramidal decussation. And those fibers eventually descend down contralaterally in the spinal cord. And of course, they will eventually innervate an anterior horn cell, which in turn innervates skeletal voluntary muscles. Thus, you can see that if there's a lesion anywhere along the brainstem, the manifestation, of course, would be contralateral paralysis. The next structure that is found in the brainstem is the medial lemniscus. So if there is a lesion affecting this anywhere along the brainstem, the manifestation is contralateral loss for conscious proprioception and vibration sense. As always, let's trace this pathway. So it's an ascending pathway. This pathway carries discriminative touch and conscious proprioception. So that information is relayed to the first order sensory neurons found in the dorsal root ganglion, which sends out fibers and enters the dorsal horn and ascends ipsilaterally in the spinal cord. This is known as the fasciculus gracilis and the fasciculus cuneatus, or collectively known as the dorsal column. Now, when those fibers eventually reach the medulla oblongata, they will decussate with second-order neurons. They will synapse with second-order neurons found in the medulla oblongata and send out fibers that cross over to the contralateral side. They will now ascend in the brainstem. This time they are called the medial lemniscus. So really the medial lemniscus and the dorsal column are the same pathway, it's continuous pathway. The difference is that dorsal column refers to the pathway when it is still found in the spinal cord, while we now refer to it as the medial lemniscus when it has reached the brainstem. Upon reaching the thalamus, it synapses with third-order neurons, which sends out fibers that will eventually terminate into Brodmann area 3, 1, 2. So again, if there's a lesion anywhere along the tract of the medial lemniscus, sensory information from the contralateral side would not be able to ascend and terminate into the cerebral cortex. Thus, there would be contralateral sensory loss for conscious proprioception, as well as discriminative touch and vibratory sense. Okay, so the third medial structure is the medial longitudinal fasciculus. If there's a lesion here, the manifestation is ipsilateral internuclear ophthalmoplegia. Let's review this pathway. This pathway is responsible for the coordinated side-to-side eye movement. So say, for example, you request that a patient look to their right side. Naturally, both eyeballs would gaze towards the right side, and then ask the patient to gaze towards the left side. Now, in a normal patient, both eyeballs should gaze towards the left side, but in this case, you have seen that this eyeball remained midline. This is a manifestation of an internuclear ophthalmoplegia, a lesion involving the medial longitudinal fasciculus. So what is this pathway? It actually is a pathway that allows coordination between the nucleus of cranial nerve number 6 and the nucleus of cranial nerve number 3. So say, for example, you want the patient to look towards the left side. Your higher center sends out fibers that would cross over to the contralateral side. That will eventually innervate the nucleus of cranial nerve number 6. This sends out fibers that eventually commands the lateral rectus to gaze, allowing the eyeball to gaze towards the left side. So naturally, this eyeball should follow, and that could happen because cranial nerve number 6 here would send out fibers that cross over to the contralateral side, and it forms now the tract we call the medial longitudinal fasciculus. This tract eventually innervates the nucleus of cranial nerve number 3 on this side right here. That in turn innervates the medial rectus. So with the contraction of the medial rectus, this muscle should also gaze towards the left side. So thus you can see that if there's a lesion affecting this tract, the MLF, the communication between the nucleus of number 6 and number 3 has been cut off. Therefore, this remains midline. So the fourth structure are the motor nucleus and nerve of cranial nerves number 3, 4, 6, and 12. We'll discuss those structures when we discuss the different cranial nerves in the middle part of our lecture here. So let's discuss now the different side structures. They all begin with the letter S. One of the structures that are located at the side would be the spinocerebellar pathway, which terminates into the cerebellum. So this is responsible for allowing you to maintain your balance. So if there is lesion affecting that, the manifestation is ipsilateral ataxia. The next structure is spinothalamic, and this structure, if there's a lesion affecting this, the manifestation would be contralateral pain and temperature sensory loss from the body. So let's trace this pathway. So this pathway carries the sensation for crude touch, pressure, as well as pain and temperature from the body. That information is relayed to the first order neuron located again on the dorsal root ganglion. This enters the dorsal horn and synapses with a neuron found on the gray matter of the spinal cord, which sends out fibers that would immediately cross over to the contralateral side and ascend as the spinothalamic tract. Upon reaching the thalamus, it synapses with third order neurons, which sends out fibers that eventually terminate into Brodmann area 312. So thus again, if there is a lesion anywhere along the brainstem affecting this tract, the sensation for pain and temperature coming from the body would not be able to reach your cerebral cortex. Thus there would be contralateral sensory loss for pain and temperature from the body. Well, the third side structure located on the brainstem is the sensory nucleus of trigeminal. And as you know, trigeminal is responsible for transmitting the sensory information coming from the face. So if there's a lesion affecting this, the manifestation would be ipsilateral facial sensory loss. Let's take a look at this nuclei because it's very long. It practically spans the entire length of the brainstem. The sensory nucleus of the trigeminal nerve is actually composed of 3 parts. So the nucleus that is located in the midbrain is what we call the mesencephalic nucleus. And then there's a component that is located in the pons. This is called the main sensory nucleus of trigeminal nerve. And then there's a component that practically spans the entire length of the vidala. This is called the spinal tract of the trigeminal nerve. The mesencephalic is responsible for receiving conscious proprioception for muscles of the face. facial expression muscles, whereas the main sensor receives touch and information sensation coming from the face, and the spinal tract receives pain and temperature information coming from the face. So if there's a lesion here, the manifestation would be numbness of the face to pain and temperature. And if there's a lesion affecting this component, the manifestation would be numbness to touch and pressure sensation to the face. Okay. So the fourth side structure would be the sympathetic pathway. So the lesion, the sign, if there's a lesion affecting the sympathetic pathway, is what we refer to as the ipsilateral Horner's syndrome. So the Horner syndrome is composed of a triad that includes meiosis, partial ptosis, and hemifacial anhydrosis. So in this patient, if you compare the two eyes, you can see that there is asymmetry. This one, the eyelid is starting to droop, so there is partial ptosis. And if you notice, the pupils are uneven. So there is constriction of this, there is meiosis, because there's now the predominance of the parasympathetic nervous system. And also, if you touch this face, it is relatively dry. So that would be the Horner syndrome. The sympathetic pathway is affected. Therefore, there would be predominance of the parasympathetic pathway. Now let's go to the different cranial nerves. Let's go to rule number 4. There are 4 cranial nerves located in the medulla. Number 9, number 10, number 11, and number 12. So if number 9 or glossopharyngeal is affected, one of the manifestations is that there would be ipsilateral pharyngeal sensory loss. Whereas if cranial nerve number 10 is affected, one of the many manifestations is contralateral palatal weakness. So let's take a look at the soft palate and the uvula. The uvula is actually lifted up by 2 skeletal muscles. This is called the levator uvulae, that is under the innervation of both the vagus nerve. Now, if this vagus nerve has been paralyzed because there's a lesion affecting that part of the brainstem, this muscles would be paralyzed, and if you ask the patient to say ah, this muscles would predominate. Thus, there would be deviation of the uvula away from the site of the lesion or away from the affected vagus. Now, then there's cranial nerve number 11, spinal accessory. If there is a lesion affecting that, the manifestation would be ipsilateral shoulder weakness. And finally, there's number 12, or hypoglossal, which controls the muscles of the tongue. So if there's a lesion affecting that, the manifestation would be ipsilateral weakness of the tongue. As a matter of fact, if you ask the patient to stick out their tongue, the tongue would deviate towards the side of the lesion. Now, just remember that the tongue is like the handlebar of a bike. So let's say, for example, you're pushing the handlebar of the bike with equal forces. The tendency of the bike is to move forward in a straight line. Now, let's say that your left hand has been paralyzed, and your right hand is now exerting a lot of pressure on the handlebar of the bike, yung manibela ng bisikleta. So when your right hand is pushing on the handlebar or manibela of the bike, the tendency of the bike, once you start pedaling, is for the bike to veer towards the left side, the site of the paralysis. Now let's go to the cranial nerves that are located in the pons. That would include trigeminal, which we have already discussed, number 6, number 7, and number 8. Let's go to number 6, abducent. So if there's a lesion for this, the manifestation would be ipsilateral eye abduction weakness. So cranial nerve number 6 is responsible for innervating the lateral rectus. So again, if you paralyze number 6, if you cut off number 6, lateral rectus would be paralyzed, and therefore there would be medial deviation of the eyeball. This is indicative of the lateral rectus being paralyzed because of dysfunction of cranial nerve number 6. Then there's number 7, facial muscle is under the innervation of cranial nerve number 7. So if there's a lesion affecting that, the manifestation will be ipsilateral facial weakness. So you can see that there would be drooping of the entire half of the face. So the entire half of the face is paralyzed, and this is indicative of a lesion affecting the facial nerve or the facial nuclei. And finally, there's number 8, of course, the auditory. So there would be ipsilateral deafness. So finally, let's take a look at the cranial nerves that are located above the pons. Number 3 and number 4 are located on the midbrain. So let's start with oculomotor. Oculomotor nerve controls all the extraocular muscles with the exception of the lateral rectus and superior oblique. So if there's a lesion of the oculomotor, the lateral rectus and superior oblique would predominate. This is the reason why the eyes are turned down and out, because of the combined movement and predominance of the lateral rectus and the oculomotor nerve. Okay, so just like what I said earlier, cranial nerve number 3 controls all extraocular muscle with the exception of the lateral rectus and superior oblique. The lateral rectus would predominate. This results in the eye being turned towards the side. And the superior oblique is responsible for a movement called intorsion. This allows your eyeball to look towards the tip of your nose. So the combined movement of the superior oblique and lateral rectus would pull the eyeball towards the side looking downwards. So the eyes are turned down and out. Also, cranial nerve number 3 partly innervates the superior palpebra superioris. So there would be ptosis, and cranial nerve number 3 is one of the components of the pupillary light reflex. So there would be absence of the pupillary light reflex. Finally, there's number 4, the trochlear nerve. So this is responsible for innervating the superior oblique. The superior oblique allows you to look at the tip of your nose. So this movement is called intorsion. So the patient would be unable to look towards the tip of their nose. But usually for patients with, okay, before we go there, let's start first with the intorsion. So this is your superior oblique. It's responsible for a movement called intorsion that allows you to look at the tip of your nose. If there's a lesion for affecting cranial nerve number 4, usually we don't see any eyeball deviation, but this is because the patient tilts their head to compensate for that deviation. So on first inspection, we don't see any deviation, but rather tilting of the head. But if you ask the patient to untilt their head, that's when you see the deviation becoming apparent. So the eyeballs are turned towards the opposite direction. So remember that you now lost the ability to look at the tip of your nose. So what would be exaggerated is the opposing movement, which is the eyeball looking upward towards the forehead. So usually, again, we don't see this because the patient would tilt their head sideways to compensate for the deviation of the eyeball. So we don't initially see the deviation, but rather what we notice is the tilting of the head. So parang nagpapakyut palagi yung paciente. All right, so those are the different neurologic structures. Now, let's put your knowledge to use. Make yourself useful. Let's put your thinking cap on and let's localize the different brainstem lesions. This is where the rule of 4 would come very handy. So it says here, pathways and tracks pass through the entire length of the brainstem and can be likened to meridians of longitude, whereas the various cranial nerves can be regarded as parallels of latitude. So if you establish where the meridians of longitude and parallels of latitude intersect, then you have established the site of the lesion. So in other words, by simply knowing where the cranial nerves arises, you can now establish the level of the lesion. So say, for example, there is deviation of the tongue. That indicates cranial nerve is affected. Then you can confidently say that the level is located at the medulla. While, say, for example, there is facial paralysis, number 7 is affected, then you can say that the lesion is more or less located in the pons. Or there is inability to look at the tip of the nose. Number 4 is affected, then the lesion is located at the level of the midbrain. Then try to decide, is it lateral or medial? If any of these structures are affected, then you can say that the lesion is lateral. Or if any of these structures are affected, then you can say that it is medial in location. So just combine the two, the different cranial nerves plus this or this, then you would establish the exact location of the lesion. Okay, so let's go back to the first case that I have mentioned, which could be a little bit of a challenge for some of you, but as it's going to turn out, it's actually very easy to localize a brainstem lesion. So we have here a 58-year-old man, and he was referred to you because of recent onset of left hemiparesis, left-sided loss of proprioception, and right-sided tongue deviation. So I have placed the symptoms and the signs into a tabulation. Let's start first by identifying the structures that are affected. Then let's identify the level in the brainstem by taking a look at the structure that is affected. And then let's take a look at the laterality, whether it's medial or lateral. Okay, so right-sided tongue deviation. I'm sure some of you have already figured out that the structure affected here is cranial nerve number 12. Left hemiparesis. This indicates a lesion affecting the corticospinal tract or the motor pathway. Whereas if this left-sided loss of conscious proprioception, then the lesion affects the medial lemniscus. Let's decide now the level. We all know that cranial nerve number 12 is located in the medulla, while motor tract or the corticospinal tract and medial lemniscus all begin with the letter M. Thus, they are medial in laterality. So by simply stringing this together, this and this will give you the exact location. So the location now is on the medial aspect of the right medulla, or you can say it's in the medulla on the right side medial aspect. So by simply stringing this together, you can localize the lesion. So the location is medial aspect of the medulla on the right side. Well, there's a special name for this type of syndrome. We call it the medial medullary syndrome. And usually this is attributed to occlusion of the vertebral artery. Let's just have a brief visualization of the location of this lesion. So we have here a cross-section of the brainstem at the level of the medulla. Shaded in red is the part of the brainstem that is affected in medial medullary syndrome. What structures are found here? The fibers that would form cranial nerve number 12 are found here. This is responsible for the deviation of the tongue. The medial lemniscus ascends in this part of the brainstem. When this is affected, there will be corresponding loss for pain and temperature cells, as well as conscious proprioception from the body. And the corticospinal tract, the pyramidal tract, or the motor pathway is also going down at this particular part of the brainstem. So there would be contralateral paralysis. Right, so let's move on to another example here. So simply use the technique that I have taught you and you will be able to localize this lesion. So here, 75-year-old woman was referred to you because of recent onset of uvula deviated to the right, left-sided meiosis, anhydrosis, and partial ptosis, and left-sided ataxia. Again, let's put it in tabulated form. Uvula deviated to the right. We all know that the lifting up of the uvula is under the control of the vagus nerve, cranial nerve number 10. And the uvula deviates opposite to the site of the lesion. So you can say that what is affected here is cranial nerve number 10 on the left side. Left-sided meiosis, anhydrosis, and partial ptosis. Well, this is indicative of, this is what we refer to. This triad is what we refer to as the Horner syndrome, indicative of a lesion affecting the sympathetic tract on the left. Left-sided ataxia. This is again indicative of the spinocerebellar tract. Okay, so let's determine now the level in the brainstem. Okay, so at what part of the brainstem does cranial nerve number 10 originate? That would be in the medulla, on the left side. Sympathetic and spinocerebellar, this begin with the letter S. So these are side structures. So let's decide their laterality. It's on the lateral aspect of the left side. So again, string this two together, you'd be able to localize the lesion. Is it located on the medulla? Yes. Lateral? Yes. Is it left side? Yes. So the lateral aspect of the medulla on the left side. So this is sometimes referred to as the laterally medullary syndrome. So there's a special name for it. We call it the Wallenberg syndrome. Usually, Wallenberg syndrome is due to occlusion of the posterior inferior cerebellar artery. So let's take it further. In lateral medullary syndrome, or the Wallenberg syndrome, aside from the manifestations that we have mentioned, there are associated analgesia and thermal analgesia of the ipsilateral phase. So the phase is numb to both pain and temperature. Why? What brainstem structure is affected here? Well, the answer is that the spinal tract nucleus of the trigeminal nerve, which receives pain and temperature sensory information coming from the face, are affected in lateral medullary syndrome. This tract runs practically the entire length of the medulla on the lateral side. So it makes sense that they could be affected in lateral medullary syndrome or Wallenberg syndrome. Okay, so let's just have a visualization of the location of the lateral medullary syndrome or Wallenberg. So shaded in red is the part of the medulla that is affected in lateral medullary syndrome or Wallenberg syndrome. What structures are affected here? Well, there's the descending sympathetic pathway. So if there's a lesion affecting that, the manifestation is Horner's syndrome. The inferior cerebellar peduncle is also located here. It's very close to it. And what tract passes through the inferior cerebellar peduncle? Spinocerebellar tract. Kaya nagkakaroon ng ataxia. Descending tract of trigeminal is also affected, as we have previously mentioned. Kaya merong loss of pain and temperature sensation coming from the face. Nucleus ambiguus is also located here. And as you know, this is one of nuclei for the vagus nerve. So nagkakaroon ng dysfunction of the vagus nerve resulting to the deviation of the uvula. Right, so let's move to case number 3. A 75-year-old woman was referred to you because of recent onset of diminution of hearing on the right, left-sided body loss for pain and temperature sense, meiosis, anhidrosis, and partial ptosis. As usual, in our strategy, let's put this in tabulation form and let's figure out what structures are affected. Let's start first with hearing diminution. This is very easy. What cranial nerve carries sensory information for auditory sensory information? That would be cranial nerve number 8 on the right. Loss of pain and temperature sensation from the body. That sensory modality is carried by spinothalamic. Meiosis, anhidrosis, ptosis, Horner syndrome. That indicates a lesion affecting the descending sympathetic pathway. So as always, let's decide what is the level of cranial nerve number 8 on the brainstem. This is located on the pons on the right side. Spinothalamic, sympathetic, they all begin with the letter S. Side structures or lateral structures on the right side. Just bring them together, string these two together, these two information. Is the pons affected? Yes. Is it the lateral aspect of the pons is affected? Is it on the right side? Yes. So the lateral aspect of the pons is affected. So that is the exact location of the lesion. Let's go back a little bit. Now this part of the pons is innervated by the superior cerebellar artery. So you can attribute this to occlusion of the superior cerebellar artery. Okay, so number 4. A 10-year-old girl was referred to you because of gradual onset of facial weakness. The entire half of the face has been paralyzed. Medial deviation of the right eye and body weakness on the left side. Let's tabulate. Facial weakness on the right side. This likely indicates a lesion affecting cranial nerve number 7 on the right side. The right eye is medially deviated, indicating that the lateral rectus is not functioning. And we all know that the lateral rectus is under the innervation of cranial nerve number 6. Body weakness. The skeletal muscles on the left side are innervated by the motor pathway or the corticospinal tract. Okay, number 7 and number 6. Let's decide their level on the brainstem. Number 7 and number 6 both originate in the pons, whereas motor or the corticospinal is medial. So string this two information together. Is it in the pons? Yes. Is it on the medial aspect? Yes. Is it on the right side? Yes. So it's in the medial aspect of the pons on the right side. Now, when the medial aspect of the pons is affected, we have a name for it. This is called the Millard-Gubler syndrome. It could be due to occlusion of an artery, but oftentimes Miller-Gubler syndrome is due to a tumor, an astrocytoma. And usually the population that are affected are the young children, pediatric patients. So if you notice in this sample case, the patient was a young child. Okay, let's move on to number 5. A 70-year-old male was referred to because of sudden onset of ophthalmoplegia. The left eye is turned down and out. There is also loss of the pupillary light reflex, both direct and consensual, on the left eye, as well as there is paralysis of the arms and the legs on the right side. Let's tabulate again. There's ophthalmoplegia, the eyes are turned down and out. That means that there is predominance of the lateral rectus and superior oblique. This indicates that cranial nerve number 3 is not functioning. Loss of pupillary light reflex has two components, number 3 and number 2. Most likely in this case, it's actually number 3 that is affected. Paralysis of arms and leg. Skeletal muscles in the body are controlled by the corticospinal tract or the motor pathway. Okay, we all know that number 3 would be located on what part of the brainstem? That would be the midbrain. Whereas motor or the corticospinal is a medial structure. What is the exact location now? Is it located on the midbrain? Yes. Medial aspect? Yes. Left side? Yes. So medial aspect of the midbrain on the left side. Now, when the medial aspect of the midbrain is affected, this could be called the Weber's syndrome. Weber syndrome. Now, there's something similar to the Weber syndrome, and this is case number 6. So in this case, a 73-year-old female was referred to you because of sudden onset of ophthalmoplegia. The eyes are again turned down and out, just like in Weber syndrome. But this is where it becomes a little different. There is loss of conscious proprioception on the body on the right side, and there's involuntary tremor and movement. So let's tabulate again. Ophthalmoplegia, the eyes are turned down and out, indicating predominance of the lateral rectus and superior oblique. This indicates dysfunction of cranial nerve number 3. Loss of conscious proprioception on the body. This indicates that the median lemniscus is not working. Involuntary tremor and movement, well, this is attributed to the red nucleus, which I did not discuss today. Okay, so you know where this is going. Number 3 is located at the midbrain. Medial lemniscus is a medial structure. So what is affected here? Medial midbrain, just like in Weber syndrome. So the medial aspect of the midbrain is also affected in this case, but this is a totally different syndrome. This is called Benedict syndrome, which is usually due to occlusion of the posterior cerebral artery. So I'm sure you're asking, what is the difference between the Weber syndrome and Benedict syndrome if they both affect the medial aspect of the midbrain? Okay, let's compare them briefly. Both of them affects cranial nerve number 3. That's their common feature. Now, Weber syndrome, aside from affecting cranial nerve number 3, would also involve the corticospinal tract, kaya nagkakaroon ng paralysis of the contralateral side of the body, and it can extend all the way up to the corticobulbar tract, kaya the face might be affected. And just like what I said, Weber is due to a lesion affecting the medial midbrain, but it's a little more anterior. Now, what about Benedict? Also cranial nerve number 3, and it involves the medial lemniscus and the red nucleus. It also affects the medial midbrain, but it's a little more towards the core. So if we're going to have a visual comparison between Weber and Benedict, they both affect the medial aspect of the brainstem. But Weber is more towards the anterior part, Medyo nasa bandang harap talaga. This results in a lesion affecting the tract that forms cranial nerve number 3, the corticospinal tract, and can extend all the way up to the cortical bulbar tract. While Benedict syndrome also affects the medial midbrain, but it's a little more towards the core, nasa bandang loob. That would result to lesion affecting the tract that forms cranial nerve number 3, the red nucleus, as well as the medial limb meniscus. So this is their difference from each other. Okay. So we are going to end our lecture not with a summary of the key points that you need to remember, but rather with an assignment, because you can only master this topic once you have practiced it on your own. So we have here a case. You are examining a patient with vertigo, vomiting, and nystagmus. And these are the clinical examination findings: left-sided limb ataxia, left-sided alteration of pain and temperature on the face, left-sided ipsilateral Horner syndrome, right-sided alteration of pain and temperature sensation affecting the arms and the leg. And there's also dysarthria, decreased gag reflex on the left, and the palate pulling up on the right side. So do localize the brainstem lesion that is presented in this patient by using the technique that I have taught you today. So I'm sure you can do it. Good luck, everyone, and this ends our lecture.